The illusion of stability of heart failure. 20% of the stable heart failure patients with paradigm heart failure had a primary event. 17% died during the course of the trial. Of the stable patients who experienced a primary event, death preceded heart failure hospitalization 51%. They died before they reached the hospital. And 60% of these deaths were sudden cardiac death. And these are so-called stable patients. So ARNI should be started as early as possible. Do not wait till deterioration occurs. So that should be the message. And you look at the latest guideline from the American Heart Association, American College of Cardiology, and Heart Failure Society of America. They come up with a guideline very recently. And what it says that in patients with heart failure with reduced ejection fraction and NAYS class 2 to 3 symptoms, the use of ARNI is recommended to reduce morbidity and mortality. So this is a class 1 recommendation. Level of recommendation is a very strong recommendation that it has to be ARNI. If somebody is not tolerating ARNI, or when use of ARNI is not feasible, then you can go for ACE or R. Only then. Otherwise, the treatment is ARNI. You should start the patient on ARNI. Then look about acute decompensated heart failure. You know, patients frequently go to the hospital, they get decompensated, diagnosed as heart failure, then they again get admitted because of acute decompensation. Are they different from the de novo heart failure? De novo heart failure are the patients who presented first time with heart failure. You look at the patient characteristic of the two different types of heart failure. And these are the patient obviously hospitalized with heart failure. Acute decompensated chronic heart failure is a old patient, it's an older population. They have got worse baseline status and laboratory findings, and they have a known history of underlying heart failure. De novo heart failure, they didn't have any history of heart failure before. Where acute this chronic heart failure, they do have a history of ischemic heart disease, COPD, atrial fibrillation, diabetes, stroke, TIA, or history of previous intervention like PCI or bypass graft. And these things were less frequent de novo heart failure. And the trigger event for them is a poor compliance in taking medication, infection and excessive salt intake, and some cardiovascular complications or interventions. So that has triggered the event. Here, the triggering events are usually cardiac ischemia or valvular incompetence, like acute MI, acute mitral regurgitation, or could be inflammatory cause like viral myocarditis, or toxic like drug-induced myocarditis. The clinical presentation is typical dyspnea, orthopnea, lower limb edema, ascites, and weight gain in a chronic heart failure who has decompensated for a de novo heart failure, basically cardiogenic shock and acute pulmonary edema.